So let us talk about post polypectomy bleeding. Post polypectomy bleeding, after polypectomy, you could see either a spurting vessel with bleeding or a clot. And if you see a clot, it's a good idea to remove the clot and see if there is a visible vessel that is amenable to endoscopic management. And let us look at various options for management of post-polypectomy bleeding. The simplest option is dilute epinephrine injection, maybe 1 in 20,000, 1 to 2 ml, close to the vessel and in the surrounding area. 1 to 2 ml aliquots should be able to control the bleeding. Because the effects of epinephrine are transitory, we should make sure that we should apply additional therapy like a clip to secure the bleeding vessel. So here is ongoing bleeding and you decide to apply the clip. The most important thing when you're applying the clip is you want to use your first clip to deploy just across the vessel and make sure that once you close the clip, you watch for the bleeding to stop. Watch for a few seconds. Make sure that the bleeding has certainly stopped before you ask your assistant to deploy the clip. If you do not follow this protocol and you apply the clip and deploy without confirming that you have stopped the bleeding, then you have wasted that real estate there and you may be applying a bunch more clips to secure that vessel. So when applying a clip, follow this protocol. Ask your assistant to open the clip, and when you are sure that you can uh, close that vessel, ask the assistant to close the vessel, and then wait for a few seconds, and then ask the assistant to deploy. So open, clip, close, clip, deploy, clip. Those 3 steps should be followed religiously so that you do not prematurely deploy a clip and then find that you have not controlled the bleeding. Very important to keep in mind. In some cases, you may not be able to apply the clip and the bleeding continues despite your AP injection. You cannot keep on injecting a lot of AP because AP could cause problems in an elderly patient, causing cardiac ischemia, etc. And you may want to apply a hemospray or one of the other newer agents that is currently available, and that will at least temporarily stop the bleeding. And then you can close the defect with a clip. Unlike peptic ulcer bleeding, post-polypectomy bleeding, especially in the right colon, not a good idea to use the contact method for coagulation because the wall has already become thin and you are at risk of causing a perforation. So when it comes to post-polypectomy bleeding, say for example, you did a polypectomy and the patient comes back with melena, most of the bleeds tend to stop on their own. Close to 80% of the bleeds stopped on their own. How do you know whether the patient has ongoing bleeding or not? In addition to looking at any other assessment, if the patient has syncope, that means patient bled a lot, that patient is likely to continue to bleed. If the patient is continuing to have bloody bowel movements every couple of hours, that patient is not going to stop and needs intervention. So what I do is, if the patient called and said, I'm having bloody bowel movements, I ask them, when was the last bowel movement? And if you said, in the last hour I had a couple of bowel movements, that patient I worry about and ask them to the emergency room. If they said, I had the last bowel movement about 6 hours ago and I've not had any further bowel movements, and he doesn't have any volume loss symptoms, no syncope, nothing, no fatigue, and no cardiac symptoms, I ask them to monitor. Or if they come to the emergency room, I ask them to be monitored and not necessarily jump and prepare them for emergency colonoscopy. Something to keep in mind. And the key is finding out when was the last bowel movement. If it is several hours ago, it's possible that the bleed has stopped on its own and may not require an intervention. I hope this is helpful. Thank you.